Anglo-Japanese Foundation. My name is Jason James. I'm the Director General of the Foundation. It's to our chairperson today to introduce the various speakers, but I will start by introducing her, and it's Holly Holder on my right here. She's a fellow in health policy at the Nuffield Trust, and I should note that, as you can see from the banner here, this event is being held in collaboration with the Nuffield Trust. Holly's current projects cover a range of areas, but one of the relevant ones is that she works on comparative analysis of international health and social care systems. And prior to joining Nuffield Trust in 2011, she was at the Centre for Analysis of Social Exclusion at the London School of Economics, where she worked on measurement of equality and human rights issues. So Holly, I'll pass over to you to introduce the speakers.
Just to say thank you all again for coming to share this evening with us, and a particular thanks to the Daiwa Foundation for letting us use this beautiful space and for partnering with us on this special occasion. We've been working on this project for quite some time now, exploring social care in Japan and England, and we're really looking forward to hearing your thoughts on what is undoubtedly a really important topic for both of our countries. I hope you'll agree that we've got some fantastic speakers here tonight. First of all, we've got Mr. Hayashi, who is the Deputy Assistant Minister for International Policy Planning at the Ministry of Health, Labour and Welfare for the Japanese government. We're particularly pleased to welcome him tonight because I think and I hope that he's travelled the furthest to be here from Tokyo. And Mr. Hayashi will begin by explaining a bit about why Japan took such radical steps in the provision of social care 13 years ago, and give us an outline of how the public have adapted and how they're feeling about the new systems that are in place, and have a little discussion with us about what the future for social care in Japan looks like. We then have Dr. Hayashi, who is a Leverhulme Early Career Fellow at King's College London. She's done extensive work looking at the treatment of older people and has done quite a lot of work comparing Japan and England. So once we've heard from Mr. Hayashi, Dr. Hayashi will lead us through some of the achievements and challenges that have come from the reform in Japan, and also begin to help us think about the comparison with England. Finally, we're very pleased to welcome the Right Honourable Paul Burstow MP, who's been an elected Member of Parliament since 1997. He was recently the Minister of State for Care Services, and amongst other things is now chairing a commission on the future of residential care in England. Mr. Burstow will talk us through the pressures facing social care in England now and also into the future, and talk through some of the challenges about reform, because in both England and Japan, both countries are going through a period of reform related to social care. So before we get going tonight, I want to let you know that there will be time for questions at the end, so if we could allow all the presentations to run through, hold your questions till then. And before we turn to Mr. Hayashi, I'm going to briefly explain the social care systems in England and Japan, and explain to you why it is that we feel that this topic is an important one. So at the Nuffield Trust, we're a research organisation. We like to do a lot of international comparisons as a way of understanding our own system here. And we felt it was important to look at social care because it's a topic that's taking up so much policy and political thought at the moment, not just in England, but in lots of countries around the world. In particular, we were interested in looking at how social care should be funded, particularly as the demand for social care is rising, and in line with that, who should be able to access state support for social care. And as part of this, we're particularly given the economic climate at the moment, we're interested in thinking about how costs can be contained and how care can be better coordinated to improve the patient experience. And so myself and some colleagues, I think Dr. Linda Patterson is here somewhere, and one of our co-authors, we went on a study trip to Japan, and we also supplemented that with lots of literature. And we wanted to find out how Japan had tackled some of these issues which we are facing in England at the moment. I'd also like to thank the British Sasakawa Foundation, who funded this research. So thank you again for that. So why Japan? if we're interested in thinking about the care of an ageing population, it seems like a pretty good place to start. It's got the oldest population in the world. It implemented reform during a period of slow economic growth, and it's still struggling with a fiscal deficit. It also recognised that services needed to be redesigned to suit the changing culture and norms within families, and understanding that more older people than previously want to be supported at home rather than moving into care or live with their family. So some of these issues are, in some ways, Japan is a few years ahead of where we are or might be working towards in England. So what actually is the system in Japan? For those of you that don't know, social care is operated under a long-term care insurance system. It was introduced in 2000. Previous to the introduction of long-term care insurance, people with social care needs were mostly dependent on their families for care and support. Long-term care insurance in Japan has got broad eligibility, which means that about 14% of people over the age of 65 are able to access social care support, which 14% of the size of the older population in Japan is actually quite a lot of people. And access is based on needs alone. So in comparison to England, income or wealth is not taken into consideration when the government decides whether or not you should be able to access some support for your care. So as the name suggests, long-term care insurance is part funded as an insurance scheme where people over the age of 40 are required to make payments, automatically comes out of people's salaries. And it's also part funded from national and local taxation. So I have a slide just to show you that. So as you'll see, half of the pie is funded through insurance contributions, and the other half is taxation contributions. The other thing to note is that this isn't the only money that comes into the system. When individuals actually receive services, they have to pay a 10% payment of the total cost up to a monthly amount. Before we look at the details of the English system, I just wanted to put up, this is probably quite disputed, but some of the goals that I was able to pick out. What we can see from both systems is that they promote independence of older people and bringing a choice of services to people. But interestingly, something which Mr. and Dr. Hayashi I think will both talk about is the fact that Japan wanted to design a system where, as it says, the second bullet point there, the relationship between benefits and burdens are made clear. Part of that was about establishing an insurance system because it was seen as more transparent than general taxation. What's interesting, I think, to note at the moment about the English system is that there's a very strong focus on social care as a concept of well-being, something broader than just addressing health or care needs. And in the assessment process, a lot of thought is given into working out what it is that individuals actually want to do with their lives and helping use the benefits and services that are able to them to lead the life that they want to live. So moving on to the details of the social care system in England, it's quite restricted and it's becoming even more so. So approximately 12% of older people receive publicly funded social care. There are other cash benefits available. This isn't the only support that's out there. But eligibility is assessed on a means and a needs test. So that instead of in Japan where it's just one examination based on what you can and can't do, the first examination in England is about your need. So there's a national eligibility framework, but at a local level, people can decide whether you're in and you're out or out. So there's the thresholds for what care level you should be to receive publicly supported social care is decided at a local level. The second is a means test. So this is, as the figure up there, £23,250,000. You need to have below that in either income or wealth or assets in order to receive state support. Both of these points are currently being debated, and I think Mr. Burstow will talk a little bit about those points later. The other interesting comparison to Japan is that individuals here can receive cash payments. So the system is slightly more flexible than in Japan in those senses. But the system is mainly funded through national taxation. And this diagram provides an example of how much care is paid for privately by individuals. This is really rough, I must just say that. It's very difficult to get exact figures for these things, and this is only for care homes. But what I hope it shows is the real extent to which in England people are self-funding their care. So we've got 44% approximately of people who fund their care completely out of pocket. And then there's this group in the middle, 22%, who receive some state support but also contribute some of their money, and then approximately 34% who are fully funded by the state. Obviously, what this also doesn't bring in is the amount of time and effort and resources that informal carers, family members, provide to individuals. And of course, that's very difficult to quantify. But those are some of the challenges that are facing the English system. And as I mentioned before, both countries are going through a period and a process of reform. Although it's important to note that the reform that's going on in England, just to put this in perspective, is nowhere near as kind of huge and really radical as what happened in Japan in 2000. Not to say that it's not important, but just so that we bear that in mind. What both of the reforms are thinking about is who should access social care, what they should pay for it, how the government can stimulate a response from both the public and providers of care themselves. And I think those are some really interesting questions which we're going to hear more about. And finally from me, just to let you know, this is our forthcoming research report, Caring for an Aging Population, Points to Consider from Reform in Japan, where all of these points will be discussed in a bit more detail. I'll now hand over to Mr. Hayashi, who will give us more detail about the situation in Japan.
Thank you. First of all, I'm very happy to have a chance to make a presentation here. My name is Hayashi, and today I got a request to make a presentation, especially the political aspects on a Japanese long-term care insurance system. Then, I identified the three agenda for this presentation, like this. So I'd like to start the first one. Why do they accept the establishment of long-term care insurance system in Japan? And this is a conclusion of the first agenda. So in Japan, under rapid aging of society due to very high life expectancy and declining and low birth rate, then we Japanese were faced to the difficulty of taking care of elder person at home, because the nuclearization of the family and increasing the participation of women and a very heavy burden a family care person is forced. These factors made it difficult for families to take care of their elder family members by their own. And also some problems with former long-term care system, and there existed some problems with former long-term care system. Then we started the discussion on how to organize a long-term care system. But absolutely, we think that we have the consensus to establish a kind of a long-term care insurance system. Then I'd like to look over the more precise data. This is the number of the population by age. Then so this is the actual data, and this is the estimation. And this red line is the percentage of the population aged 75 and over. And this orange line, this is the percentage of the population aged 65 to 74. For example, in 2025, we 12.3 plus 18.1, that is about around the 30% of the population is aged over 65. Then finally, the 2055, we have the more than 25% of 75 and elder population. That is very serious one. That's very serious. Then also this is the international comparison based on the data of the OECD. So this is the percentage of population over 80 in OECD countries. This red line is Japan. And this gray line is the EU 27 average. And this blue line is the OECD average. Then, so in Japan, around the 2045, it goes more than 16% of the population that is 80 years old and older. Then, and I explained the third factor, that is a very heavy burden a family care person is forced. Then we had a very shocked outcomes from the public opinion poll and the surveys. First one is a survey conducted by the ministry. So you have a difficulty in house care. Then around 60% of persons says we have a too heavy workload for the meal or bath and elimination like that. But the most shocking data is this one. This is a survey by the trade union, the Japanese Trade Union Confederation. So you feel hatred against the person who requires the nursing care. Then, so daughter-in-law, that means the wife who nurses her husband's parents, it around 50% felt hatred against their parents-in-law. And also, I pointed out that some problems on the system at that time. Then, so it's so complicated, but just a very simple. I explained a little about for the former system. The municipals decided the types of the service and their providers. That is one problem. And income verification was required, for example. And municipals generally provided service directly or via commission and some organizations. And companies are based on the income of the individual and persons with the duty of support. And that is the problems. Then after introducing the long-term care insurance, that is completely changed. For example, the users can choose the type of the service by themselves. And a long-term care service care plan is created then, so a comprehensive use is made of the medical and welfare service. It's combined. And the services are provided by diverse vendors, including private sector firms, and so there is some competition in the service. The quality of service is fairly improved. And also the users have to pay 10% of the service they got. Then finally, we can success to introduce the long-term care insurance system. Then after introducing the long-term care insurance system, what's the evaluation of the system, and what is the challenge? Very quickly. So, about 60% of persons are appreciating a long-term care insurance system. 47 plus 19. And family, how about the family burden? So family burden becomes lighter. Yes, more than half says yes. And how about the quality of service? About 34% says yes. And the selection of services and the service providers get easier. About 50% says yes. So fairly, I feel that this evaluation is very good. Then this one is another aspect of the concerning the long-term care system, because I identify this in the third agenda. I will explain the future of long-term care. Then this is very important for the discussing the future of the long-term care system. So this is a question like this: if you need long-term care, how do you want to receive a long-term care if you come to need it? Then around half of them says we'd like to receive long-term care at home if there are services that enable me to live at home independently of my family members. Then it's another one. If your parents need long-term care, how do you want your parents to receive long-term care if they come to need it? Then about the half of them choose that live at home, receiving a combination of external long-term care services and care by my family. Then these outcomes show our challenges for the future. Then this is the conclusion of the third agenda. Okay. So especially these two outcomes of the survey, we really need a integrated community care system. That is important. Because most of them would like to get that care in house, but they wouldn't like to owe the burden to their family. Then so that all of the community have to take care of the elders, linking in long-term care facilities and health care and supporters. And of course, from an aspect of financing, long-term care cost must increase, and the insurance contribution will also increase like this. And therefore, we have to make efforts to keep the system acceptable for people, including people who don't use the services. Then we have to find the best balance of services provided and contributions carefully. It's a very important point that how to make a balance. Thank you.
It's a great honor to be invited to participate in today's session. I'd like to build on the presentations given by Hori and Mr. Hayashi. First, to consider the experiences of Japan's new system during the phase of expansion after 2000 and reform since 2005. I'll then address one of the key reforms, creating a comprehensive support network, and conclude by assessing Japan's major achievements, challenges, and possible lessons for England. First, the initial expansion phase from 2000 and 2005. A fundamental aim of government was to win acceptance for the new system by encouraging people to use services. This approach succeeded, and initially generous eligibility criteria prompted a rapid expansion in service users and consequent reduction in unmet need. The system's growing popularity suggests success in tackling the stigma of public care. There was a growing sense of entitlement and willingness to pay premiums. Ironically, however, these achievements increased expenditure, leading to increased funding through both taxes and insurance premiums. Also, it was claimed that removing means testing and relaxing eligibility criteria revealed latent demand and even encouraged the abuse of services, particularly unwarranted use of home care by less needy people, tapping into the system and paying only a 10% user fee instead of the full market rate for private domestic help. This aggravated soaring care expenditure. Accordingly, the government introduced measures to ensure the system's sustainability. Reforms in 2005 introduced means-tested accommodation fees in nursing homes and clearly defined and reduced services for less needy groups, placing a new emphasis on no-frills, rehabilitation-led preventative services at the cost of domestic help. This slowed the growth of eligible users and of service use, permitting stabilized expenditure. The second aspect of the government reforms was to make the system more comprehensive. Municipalities, the insurers, were made responsible for low-level and preventative support with ring-fenced funding, involving active public participation, particularly from older people. Here, healthy seniors are encouraged to offer voluntary support to frail older people, which in turn promotes healthy and active lives. In some municipalities, these volunteers earn credits which can be used towards their own insurance premiums. This initiative has potential as a cost-effective alternative to public support by paid workers. Significantly, the system's scope was actually extended to provide comprehensive support, offering core care, prevention, rehabilitation, and opportunities for active aging to the entire older population. I'd like to conclude by briefly summarizing the system's overall achievements, its challenges, and the lessons learned. First, the achievements. Above all, Japan's system, one of the most generous public long-term care systems in the world, has achieved financial sustainability with controlled and stable increases in expenditure. Secondly, the system's generous, inclusive approach involves the wider older population, fostering higher service quality and user expectations, and promoting prevention and active aging. Its universalist approach and popularity triggered a profound culture shift in attitudes towards responsibilities for the care of older people. Japanese people now overwhelmingly express a preference for public care over care by the family. However, some challenges remain. First, maintaining financial sustainability remains a huge challenge. By 2025, care expenditure must double just to match the doubling of the population over 75. This requires higher premiums, increased taxation, larger user fees, reduced services, or a combination of these. All these options could prove to be controversial, and currently discussions are heated. Secondly, unequal service distribution is still unresolved, producing acute shortages of nursing homes and intensive community care, leaving a heavy burden on family carers. Thirdly, increasing financial burdens on low-income older people cause concern, reflected in low service uptake, although safety net measures are intended to address this. Finally, there is an immediate problem of the shortage of care workers, particularly in the home care sector. Japan may need to relax its immigration policy to meet this need, but this issue has enormous political implications. Finally, what can we learn from Japan's experience? I'd like to raise 4 points. First and foremost, Japan's new system suggests that cost control is possible, even within a needs-led, universal pay-as-you-go approach. This perhaps contrasts with tax-based, budget-driven systems like England's. Yet, this requires careful negotiation among all those involved, plus popular trust in the system, particularly because people are contributing directly in the form of premiums. The Japanese case suggests that this is possible, provided that the approach is equitable and clearly understood. Winning wide-ranging support among contributors, intergenerational equity and solidarity are key concepts. And Japan's system involves every pensioner as well as workers paying premiums. It's also important that premiums are paid on a progressive sliding scale according to financial means to address equity between generations. Secondly, given that trust and support underpin financial sustainability, cost-cutting measures which restrict eligibility, increase user fees, and reduce services can be counterproductive and have only temporary gains. Japan took an interesting longer-term approach, actually widening eligibility and services with a new focus on prevention and active aging. We've also learned that universal entitlement reinforces quality, since a large and diverse range of users, not only the most vulnerable, is included. This contrasts with England's system, which targets the most needy. A developing consumer mentality among Japanese users helps consolidating the reformed system, while England's approach to quality assurance tend to remain inspection-led. However, such user-led and consumerist attitudes may encourage unrealistic expectations or the abuse or overuse of services. So, we've learned that clarity concerning eligibility and service content are crucial, which is the third point. Early, exaggerated expectations and variations in service content antagonize users and providers alike. This problem is only emphasized in the regime which increasingly highlights person-centered care and the benefit of flexibility. Significantly, there is little discussion in Japan of personal budgets or personalization, so prominent in English discourse. Nor does the Japanese system provide for cash allowances to support care by the family. The emphasis here is on socialized care. Finally, achievements in containing costs and recent policy adjustments assume strong central government control and flexible funding and system structures. Also important is a clear role and autonomy for municipalities as insurers. Municipalities set out their own care budgets according to their local service needs. This contrasts with England, where local authorities mainly rely on central government funding. Thank you very much.
Right, well thank you very much for the opportunity to listen to and then respond to perhaps some of the lessons from Japan. I'm going to put my first slide up, if it hopefully will work. Yes. What I'm going to do is try and give both a bit of context from our reforms that are just on the sort of cusp of being implemented, and some reflections on what I've heard from the presentation so far. I think the first thing I want to say is that we often frame discussions about ageing in terms of disbelief that this is happening to us, that this is some sort of crisis that is of someone else's making, when in fact it is a triumph of human ingenuity and the product of deliberate policy actions over many generations. And in that sense, the slides I want to put up next really just sort of show that this is not just a Japanese challenge, it's not just a UK challenge, it's a global challenge. And what I'm just going to show is a series of pictures of the planet, and if you follow the yellow, you'll see what I mean. So this is the population of over 65s in 2015, and then it just runs through to the end of the century. And what you'll see is that by the end of the century, on current forecasts for the change in the demographic profile of our global population, there will be a much older profile to the whole planet, and not just confined to the north of the planet, but globally, encroaching significantly into Africa as well. And this, I think, does have profound implications for long-term care, not just in the UK, but globally, in terms of how we encounter ageism. So let me just put up another graph which just shows what I think is a really significant part about this, the fact that we are talking about a revolution in survival that has taken place over the last century because of public health, because of clean water, clean air, vaccinations, antibiotics, and then the establishment of national health services of one sort or another, and certainly in the UK context, the NHS. And this graph just shows the numbers of centenarians, people over the age of 100 between now 1981 and 2081. And if you consider that in 2048, when the NHS celebrates its 100th birthday, there will be over 100,000 centenarians. You can begin to sort of see the context in which policy has to develop in this country. And then the final graph I think I want to show you at the moment is one that just shows that the fastest growing part of our population are the over 80s, the 85 pluses. And we make an awful lot of assumptions about this part of our population. We don't have really as good an evidence base as we should have. And as a result of that, I think we do need to see a much greater emphasis on research going forward. When we do look at the research that exists, certainly domestically in the UK, often that evidence paints a rather different picture to the one of doom and gloom that is very often characterised in a discourse in terms of ageing. I'd draw particular attention to the work done by the Newcastle University and their ageing centre, and the work they have done on a 1928 cohort study over a number of years, where they have shown quite significantly that the oldest of our population, many of them, in fact the vast majority of them, will be living independently, albeit with some complex comorbidities, but their quality of life is self-reported as good, and all too often that is overlooked. And about 8 out of 10 of that population, a representative sample of the UK, is living independently. Now that of course still leaves us with 2 out of 10, and 2 out of 10 of a larger and growing part of our population, and in there lies the challenge. And perhaps my last graph is just to say in a slightly different way the point about the balance between informal care given by families and formal care. And indeed I think the ONS today have just published the new dependency ratio figure, which is of these two graphs the line, can't see the line that goes up there, which shows that over this period the number by 2030 there will be about 6 people available in the workforce compared to those that are economically inactive at both ends of the age spectrum. And this is going to be a significant climb during the rest of this century. But in some ways, the graph that's even more interesting is this one, which shows the ratio of the oldest old to those that are in our older part of the population, people between the ages of 50 and 75. And again, there is a steep decline during the course of this century. And that does have some quite wide and significant public policy implications, not just for the UK, but globally, in terms of impacts on our labour market and how labour markets will tighten as a consequence of this change in family composition. And it will require a different mix of both social and economic policies in order to enable people to struggle and effectively manage that balance between caring responsibilities and a desire to retain more people in the workforce going forward. Now, I don't think we've got the polling data that was cited earlier on in the context of how family carers in the UK think about their responsibilities. What we do hear frequently is a sense that they are undervalued, not recognised and not properly supported. Whether that translates into polling evidence yet that would suggest hatred, I think is something which may well be an interesting area for Nuffield to commission research on. So let me just talk about the reforms. It's worth just saying actually in the 1980s and 90s there were some tentative reforms around care in the community care, and principally a significant shift of funding responsibility from our benefit system to local authorities. And that did give local authorities a responsibility for capping and controlling costs in this sector, and with some success during the 80s and 90s. But I want now perhaps to just say a bit about the reforms that the Care and Support White Paper that was published in 2012 set out. And I think there are some quite significant shifts implied by that white paper and hopefully fulfilled by the legislation that's going through at the moment. And I think there are four particularly important shifts. First is a shift from a more welfare model to one that is focused on promoting individual well-being, and there's a new legal duty that will have effect from 2015 on local authorities when they are conceiving services. I would challenge the notion at the moment that the way in which elder care in this country is regularly commissioned is one that puts well-being at the forefront. Indeed, if one was to compare a package of home care for a working age adult with an older person, you would find the latter was focused on citizenship and their participation in wider society. The older person's one would be focused on tasks, and all too often tasks delivered in 15 minutes. So there is a difference there which has to be overcome. It sits at the heart of quite a lot of this. It's called ageism, and it does manifest itself in the way our system currently works. Wellbeing is about trying to shift that. Secondly, moving the system from one that is about rescue and sorting out crisis to one that is about prevention, and making sure that we have a system that has a prevention duty that is not just for those that the state will have a direct financial responsibility for, but indeed for the whole of the population. So there is a universal duty there that will come onto local authorities going forward. Thirdly, a shift from fragmentation to one that promotes as a default mode integration. There is a funding announcement that was made by Department of Health just recently, about £3.8 billion that will be available to local authorities in the health service in 2015-16, and work preparatory to that, which is all about driving a prevention agenda and an agenda around integration of services and pooling of budgets across our health and care system. And then the final piece is around a shift from what I would describe as transactional models, of which 15-minute chunks of care is certainly part, to one that is really focused on promoting relationships. And this speaks to issues of social isolation and loneliness, which can be really big drivers of healthcare costs and care costs in our system, and relationships, and promoting and maintaining social connectedness is a key component in any strategy that is going to bend the demand curve, to reduce demand, or certainly slow down the increase in demand going forward. So the Care Bill is intended to be a legislative framework, shifting some of the approaches going forward, moving the system from one that is about border patrol and access to one that is fundamentally about saying, where are the hidden treasures in our communities, where are the assets that we can access that enable people to maintain themselves independently in their communities. The next slide is about funding reform. Some people in an English context will think that the only thing the government has actually been doing is about how we pay for care in this country, and in fact the reform is a much more comprehensive one than that. But when it comes to funding reform, I think there are a number of important shifts. The first is that for the first time the state is accepting a responsibility for taking on the tail end risk of care costs, the catastrophic piece of care cost that can wipe a person out financially. Is also recognising that that means test figure that you saw earlier, the 23,250, is the meanest of means tests in our whole system and is to be increased to about £118,000, and in fact will probably have the biggest of impacts in terms of people on middle incomes going forward. And I think a point I would take from the presentation earlier on, in terms of communication of these changes, one of the things we will have to be effective at getting across is that this is a no frills package, that you will not be being paid, having care paid for at the level you might have self-funded at. The state will pick up the notional cost that it would have paid for someone that it was always going to have a responsibility for. And communicating that well is going to be very important, which leads me perhaps to one of the biggest challenges of all, which is that in this country, people think care is free. About 1 in 4 at least, and probably more than that, think that the social care system is just like the NHS, probably is part of the NHS, and therefore will be shocked, and indeed in many cases are shocked when they discover that it is a paid-for system and they will be means tested. The government has a challenge to communicate the reality so that when people are confronted with the reforms that the government is introducing, they don't measure it against the fantasy, and as a result feel very aggrieved that they discover that. And just to draw my remarks, as I've been told, to a conclusion, I want to just cover off some quick points about challenges. Biggest one is about stigma. We need to move this whole debate about an ageing society to one that is couched and framed as a positive one. We need leadership that moves from institutional boundaries to one that is focused on leadership across systems. Similarly, we need a workforce that is not based around silos, it is based around teams, much more versatile workforce going forward across health and care. We need money in the sense that we need to move from a short-term spending review period of 3 or 4 years to at least 5 years plus 5-year forecast. There's no doubt in my mind if we're to get some of the significant shifts in our system that will be essential to its long-term sustainability, it requires that level of certainty in the system for leaders to lead, and that's where the trust piece comes in. We have a 1940s healthcare system, and the only way politicians and other leaders are going to move from a 1940 healthcare system is if we can give people the confidence and trust that there is going to be both suitable housing for them and that the care that will be provided in their homes is actually sufficient. It shows that rather than a burden, older people in our society contribute £175 billion a year gross and contribute net over £44 billion a year. We need to shift the debate, we need to deconstruct it and reconstruct it in positive terms, because that's an essential part of delivering these changes.
Before we move on to the audience discussion, I'll just say a few points that I think kind of bring together the presentations that we've heard today. So, first of all, thank you so much for the presentations we've seen, and I think it's really an interesting topic in terms of the demographics we've seen and how important this is. I think also demand and access to services is an important part of this debate, as we've been hearing, and whether directly or indirectly people are trying to restrict support to those who are most in need. And it's an interesting idea for Japan about whether or not you'll begin to see a large privately funded market for social care, and something that you haven't had before, and how you will monitor the quality of those services. In both countries, we've seen a recognition to change attitudes towards ageing and to care. We've also seen a need to bring clarity to eligibility and the services that people can receive, but how that links to the personalisation agenda, particularly in England, and whether or not that needs to come a bit more into Japan is interesting. And we heard a little bit about prevention services. And it'd be interesting to have a think about how, with restricted budgets, whether or not those preventative services are still being delivered as they should be.